All right, everybody. I know you've been waiting all year for this December MEC Minute, and I hopefully don't disappoint you. So our uh, annual December MEC meeting or MEC Minute is always a protocol review, and I'm going to go through what we've got in plan and in store for you for next year. So really for today, we're going to discuss the changes to the protocol, particularly the bigger ones. We've done a lot of things that have to do with edits and some format changes, but I'm going to cover what I think are the bigger things. And I'm also going to clarify a couple protocol items as part of the conversation. So this year we've had a new process. ResponseSoft asked us if we could have our own staff make changes to the protocol, and we have agreed. And Cody Smith and Ben Matthews have stepped up and have been trained by ResponseSoft to help make protocol edits. We're learning as we go. It's taken a bit more time than the old days when I could send some things off to ResponseSoft and it gets done fairly quickly. But I think it's a good thing. And actually, it's improved our process for protocol reviews. We've had a lot more involvement of EMS coordinators and others. So I think it's a good thing. It's slowed us down a little bit. We've got a couple more hoops to jump through before the official release of the protocol. Because we want to do some error or review for errors and completeness. But what I'm going to talk about today has all been finalized, and what we've got today is the real deal. Should have the final protocol distributed to EMS coordinators as a PDF for distribution to everybody by the 20th of this month. Uh, as with all previous iterations of the protocol, there is a protocol change list. It's toward the back of the protocol. I suggest that once this is released and the PDF goes out, that you take a look at the protocol changes and make sure you're comfortable with the changes that we've made. So there will be a protocol change list as part of the protocol. It's toward the back. Use it as a reference, take a look at it, and maybe sit down with your other crew members and talk about the changes, even if we don't have all the changes listed in this video. Take a look at the list. So the bigger changes, we've made some changes to the protocol related to EMT scope of practice. This has to do with the additions to the EMT scope by the MFATS board this year. We've added bronchodilators to the protocol for EMTs. Actually, no change, just now they are allowed to do it. Glucagon is now available or will be available for EMTs to administer to hypoglycemic patients, as will IM epinephrine. IM epinephrine we rolled out earlier in the year. In terms of EMTs with glucagon and bronchodilators, they must have training through their coordinators to make sure they are aware of how to properly set up a nebulizer, how to properly administer the medications, how to set up and administer the glucagon, and how to thoroughly evaluate a patient before and after they're treated for hypoglycemia. One of the things we've added Toradol as a non-narcotic alternative for pain. So this is an injectable medication that can be given either IV or IM. We've expanded some of the indications for TXA, and I'll talk about that in a minute. We've also looked at our protocol for extremity trauma. I'll go into detail later, but one of the parts of this change in the protocol has to do with the addition of Ansef, which is an antibiotic for open fractures and amputations. At the suggestion of Dr. Kadish, we've added a pediatric sepsis protocol, and we've also added a new job aid to assist in the identification of child abuse. And I'll go through each of these things later on in this conversation. Some cleanup items that we've done. Ketamine has been added to our protocol for use to sedate patients who are on CPAP or BiPAP. So ketamine is in scope of practice for advanced EMTs and paramedics, and the protocol will be adjusted to allow ketamine to be used for a patient who requires some sedation in order to facilitate use of CPAP or BiPAP. We have made some clarifications to our CPAP and BiPAP protocol. CPAP is within scope for all levels of certification. However, BiPAP is restricted to paramedic use only. So it may seem a little tricky. An AEMT can start CPAP. They can give ketamine for CPAP sedation, but they cannot administer BiPAP. So if you are an advanced EMT or an EMT, please make sure when you set the device up that you have it switched on as CPAP mode, not BiPAP mode. We've looked at the adult and pediatric allergic reaction protocols. We have pretty much set it up so that the epinephrine protocol or procedure is the same for all levels of certification. So instead of having multiple branches to the allergic reaction, if the patient requires epinephrine, the dosing schedule is the same whether you're EMT, advanced, or paramedic. We've had some questions about termination resuscitation and whether bystander or other medical professionals providing resuscitative efforts prior to arrival, whether that time can be considered as part of TOR. And yes, we will do that, and I'll talk about it in a bit. For clarification's sake, we've upgraded our hospital matrix for destinations. We've included outlying hospitals such as Genesis, FMC, and LMH, and hopefully that will be useful. Also, going to have some discussion on swoop and scoop for penetrating trauma. So any trauma patient who has penetrating trauma proximal to the elbows, proximal to the knees, or involving the trunk will be quickly moved into the truck, and interventions will be performed during transport and not at the scene. Uh, Rocuronium is going to replace succinylcholine. So succinylcholine will stay as an alternate medication to rocuronium if rocuronium is unavailable, but our go-to drug for chemical paralysis in patients requiring airways will be rocuronium beginning the first of the year. Midazolam, we've tweaked a little bit. At one point, not that long ago, I was thinking about taking intranasal midazolam out of the protocol. Many people advocated that we keep it, but we've now changed midazolam for seizures in terms of administration routes so that IM is preferred over intranasal. So if you come on scene, you have a patient who's having a seizure, and you want to administer midazolam, no IV is in place. My preference is we go to IM first. That way we know the patient's getting their full dose, and we can move on. If you elect to use intranasal, you may, and the dosing schedule for intranasal midazolam has not changed. The other thing we've added at the suggestion of several of our EMS coordinators is adding IM or IV midazolam to our trauma protocols so that you can use midazolam to augment or supplement fentanyl when moving a trauma patient. So if you have a patient in the middle of a cornfield and they need to be placed on a backboard and moved out because they have a fractured femur, fentanyl's not enough. You can use midazolam to augment. Remember, your other option is to use ketamine to augment the fentanyl. So we're giving you yet another option. Let's talk about some EMT updates. Just something to keep in mind. EMTs can do more things now, but we have to train them on the medications that they're administering and how to document that medication. Epinephrine has been formally added as an EMT procedure. I'll discuss that a little bit later when I talk about the formatting changes. Bronchodilators, EMTs can now administer nebulized bronchodilators to patients with bronchospasm. EMS coordinators must be aware that they have to appropriately train the EMTs on how to set up the device and how to properly administer the medication. And the EMTs need to be aware of the side effects of the medications they're administering. Glucagon is added now for hypoglycemia. It can be used intranasally, intramuscularly by an EMT. Paramedics can give glucagon IV, EMTs cannot. From my perspective, like midazolam, if you're going to treat a patient as an EMT, the intramuscular route is preferred. But you can give it intranasally. Keep in mind that glucagon is expensive. For us right now, our list price from Boundtree with our discounts, $252 per 1 milligram dose. Also keep in mind that it's not effective if the patient has significant liver disease. And if the patient's got jaundice and a big belly from ascites and they're hypoglycemic, glucagon is probably not going to work. And also keep in mind that if the patient's hypoglycemic, you treat them with glucagon, you need to give them or do a follow-up finger stick blood sugar once they've shown some recovery. Just a little bit more about glucagon since we're expanding into the EMT world. We do have our protocol that covers glucagon. We have our medication instruction sheet. For EMTs, they can use glucagon IM or IN for hypoglycemia. They cannot use it for esophageal foreign body like our paramedics can. So if you're an EMT now, please make sure you look at the glucagon page so you're aware of the side effects of the medication. Well, how does glucagon work? Why is it important that you have a healthy liver? Well, if you have a patient who is hyperglycemic, it stimulates the pancreas to put out more insulin, the blood sugar goes down. If you are a patient who is hypoglycemic, another portion of the pancreas will stimulate glucagon secretion. Glucagon affects the liver. Glucose is stored in the liver in the form of something called glycogen. Glucagon causes glycogen to break down and be released in the blood as glucose. If you have a diseased cirrhotic liver, you have no glycogen stores, so there's nothing for glucagon to work on, and it really will not help the patient. So, just as a teaching item for the day, if you have a patient with severe liver disease who's hypoglycemic, glucagon is probably not going to work. Some ideas or comments about Toradol. Toradol, I tell people, I tell patients, is essentially an IV version of ibuprofen. So you give somebody a dose of Toradol. You can use it for pain. If you look at our algorithm now, I've got a copy of the new one. You have three options instead of two. You can use fentanyl, you can use ketamine, you can use Toradol. If you have a patient that has low to moderate pain, Toradol is a good option. It works very well for kidney stones. If you give a patient a dose of Toradol and it doesn't work, you can then go to fentanyl or ketamine. So Toradol in itself does not keep you from going to one of the other treatment medications for pain if the patient needs it. If the patient has an allergy to aspirin, ibuprofen, or naproxen, then Toradol is contraindicated. Toradol is in the same class of medications as ibuprofen and naproxen. If the patient has a true allergy, meaning rash, wheezing, facial swelling, typical allergic reaction symptoms to aspirin, ibuprofen, or naproxen, do not give them Toradol. The adult dose for Toradol is 15 milligrams intramuscular or IV, and for children, it's a half a milligram per kilogram IM or IV to the maximum dose of 15. So if you have a child who's 30 kilograms or more, they get the same dose of Toradol as an adult. We've also added some additional indications for TXA. The big one is really postpartum hemorrhage, and it really works well. So postpartum hemorrhage, by definition, is that heavy vaginal bleeding within 4. Sometimes people define it 6 weeks of delivery. We'll go with 4 weeks. And postpartum hemorrhage can be a disaster. We've had several patients in the past few years who just bleed out. They delivered a baby 2 weeks ago. Now they come in and they need immediate transfusion on arrival. TXA is part of the treatment for postpartum hemorrhage. So if you have a patient who's got heavy vaginal bleeding within 4 weeks of the delivery, whether it's vaginal or cesarean, you can administer TXA in the same fashion as if the patient is a victim of trauma. We've also can use TXA for epistaxis. You put up to 500 milligrams on a cotton ball and have the patient insert it in their nose. I talked about it last month as part of the ENT emergencies. Extremity trauma, we've simplified the algorithm. The old algorithm had 2 or 3 arms to it. We're down to 1 arm. I've had a lot of conversations with our orthopedic traumatologists, and they all kind of the same opinion that patients who suffer an amputation should be transported to the closest trauma center based on the trauma triage guidelines. Rarely do amputations get replanted. If you have an isolated digital amputation of the hand, so finger or thumb is amputated, our destination of choice right now is OSU Wexner. The hand service at Riverside is not as vigorous as it used to be. Several of those physicians have retired. So OSU Wexner OSU Wexner and then Nationwide for Kids are our 2 preferred destinations for finger amputations. We no longer have to give aspirin. Again, we've added midazolam as an option to augment pain control during extrication and movement for patients with fractures. And then we've added Ancef as a antibiotic for open fractures and amputations. I'll talk about that in a moment. So for extremity trauma, this is a simplified algorithm. You can see it's one branch. There's no offshoots to it. Pulling up some of the high points. If we have a patient with extremity trauma, severe bleeding, we're going to provide bleeding control with either direct pressure or quick clot or tourniquet. If you suspect a pelvis fracture, you can apply a pelvic sling. Pelvic slings do a great job of slowing down the bleeding. Again, if the patient's bleeding out and they have a large amount of bleeding, you control the bleeding. If you have the chance, you get IV starter, you give TXA. And we give TXA 2 grams over 10 minutes. Just as a sidebar, Columbus Fire is moving to TXA for the first time. They're going to administer TXA 500 milligrams in each thigh, so they're not giving it IV. It's basically a 1 gram dose intramuscularly split among two muscle bodies. So you may see that in the field if Columbus Fire is coming in to help it with a trauma patient. If you look at the bottom of the algorithm, we get into comments about for partial to complete amputations or suspected open fractures. They get ANSEF, which is a cephalosporin antibiotic. They get 2 grams over 5 to 10 minutes. Next slide, we'll talk about ANSEF. ANSEF is important. It helps reduce the risk of infection, but in the field, it's really one of your lower priorities. ABCs, bleeding control, patient stabilization is more important than ANSEF. But if you have an opportunity to give ANSEF, give it. Whether it's open fracture from an isolated extremity injury or a patient's multiple trauma with multiple open fractures. So with extremity trauma, we're going to look for amputations or injuries. We're going to immobilize the body parts. We're going to control the bleeding. If you have an open wound, we want to use saline moistened gauze to the fractures or amputations. If you have a wound that's grossly contaminated, and if you have the opportunity, you would rinse it off with some sterile saline just to get the junk and the dirt out of there. And then if you have any amputated parts, transport them with moistened gauze. Again, my orthopedic traumatologists estimate at least 95% of amputations do not get replanted. Take amputations to the closest appropriate trauma facility. And then finally, if you have an isolated finger amputation, OSU, Wexner, or Nationwide. IV ANSEF. So a little bit of discussion of ANSEF. ANSEF is an antibiotic. It's a cephalosporin. If you're aware of cephalexin or Keflex, which is an oral cephalosporin, ANSEF is the IV equivalent. It is generally well tolerated, particularly if you give it IV. Our dosing is going to be 2 grams IV or IO for adult patients with amputations or obvious or suspected open fractures. What is an open fracture? It's visible bone that's coming through the skin or that you can see through a wound, or you have a suspected fracture with a wound on top of it. Let's say you have a femur fracture, the femur is unstable, and there's a laceration of the anterior thigh. You don't see the bone sticking out, but there's a fracture overlying where you think, or sorry, a laceration overlying where you think the fracture is. That is an open fracture we are going to treat with ANSEF. If the patient has a penicillin allergy, first thing I would do is to verify their symptoms. Most people who say they have penicillin allergy, it's because it gives them GI upset. That's a side effect. It's not an allergy. But even if they do have documented penicillin allergy with rash or wheezing or facial swelling, there's a better than 95% chance that they're not going to have any issue with ANSEF. So if the patient has penicillin allergy, you can safely administer ANSEF to that patient. If the patient says they have an allergy to Keflex or some other cephalosporin, do not administer ANSEF. There is a chance of cross-reactivity there. So true penicillin allergy, no problem. True Keflex or other cephalosporin allergy, do not give the ANSEF in the field. We're going to give 2 grams of ANSEF mixed in 100 mLs of saline. We're going to use this binary adapter. In a moment, you're going to see a video on that. The binary adapter you can use to reconstitute the dry powder that's in the vial with the cephalosporin. Once you get it mixed up, you're going to infuse it with a big drip tubing. Just open it up, let it run in. For those patients that are critically injured, you have other priorities. ANSEF is a lower priority. If you got 10-minute transport time, you can get it hanging in route, no problem. But don't let the ANSEF interfere with other priorities in the patient. Next slide up is going to be a slide by Ginger. I'm going to let you listen. It's about 7.5 minutes, and I'll be back after that.
One of which is our Rosefin, 2 grams. We get it from Boundtree. And then the other piece, which is kind of a newer addition to our protocol and to our practice, this is called a AdEase binary adapter. This is going to be the piece that's going to make the connection between the powdered Rosefin and the IV bag. So we're using, and again, we're getting all of our products from Boundtree. We're using 100 ml. It's called a partial fill. It's actually called a partial, a PAB. P as in Paul, A as in Adam, B as in Bravo bag. It's different in regards to our other 100 cc bags. If you look at the medication port on this one, it's just a straight port with a rubber stopper. If we look closer at this medication port, there's actually a clip, a ring around the end of it. That's going to come important here in just a few seconds. So what we're going to do is we're going to identify that we need to use it. We also have our full flow drip set. We're going to take our Ad-Ease adapter and you're going to twist it. When you twist it, the clear end is going to come off first. So we're going to take the clear end off. It doesn't go unnoticed. You look at it and you're like, oh, it's plastic, no big deal. It's got a needle on it. It will go through the palm of your hand if you would grab a hold of it. So the fact that it's plastic, don't take that as a misnomer that it's not really that strong for all intents and purposes. So what we're going to do then is we're going to take the cap off of our safety cap, and we're going to place our adapter, and we're going to basically make this connection between our Rocephin and the bottle. You'll hear it kind of snap on, and you'll see the teeth will grab around the ring. Then what we're going to do is when we're ready, we're going to also take the cap off the end of our bag. So we see our rubber stopper. You're going to pull the green cap off. You're going to see a U shape. The needle is down inside there. And what you're going to do is it only fits on one way. So it's going to go on this horseshoe. And we're going to press until we hear it click in. So now basically what's happened is we've connected the pieces to where they don't come apart. If you pull hard enough, yes, they will come apart. But for all intents and purposes, for us using it, it will not come apart. The nice thing also is now, if there's any question about what's in the bag, we know that it's the Rocephin because the ceftriaxone is connected directly to the bag. We also have a label in the kit from Mount Carmel that we would put on it. But for emergency purposes, this actually connects it, which lets us know that there is a medication in this bag. So now if you'll notice, we still have powder in here and our liquid in here. So what we're going to do is you're going to turn the bag so it's upright with the bottle at the bottom. You're going to fold it at about the, I don't know, a fourth of the way down, or about in between the two lines on the label line and the empty line, or your zero line. We're going to fold it over and we're going to squeeze the bag, and you're going to hear like a little pop, and there's a little pin. There's a plug in between the two. Once it goes, you're going to see fluid come in. You want to get enough fluid to where you can start to mix up the liquid. I would encourage you not to fill the vial, because the farther you fill the vial, the longer it's going to take you to reconstitute, to get it back into the bag when we're done. So you want to fill enough to get it done. I would avoid shaking it. We're always taught basically we don't shake it, we stir it. You can also turn it upside down and spin it if you need to, or roll it within your hands. So you want to spin it or swirl it around until basically your chunks are gone and most of your precipitate is gone. Or basically we look at it as a kind of a clear. Fun fact, I'll save everybody for what I learned kind of the hard way. This little white piece in here, a lot of times I always thought, for a long time, thought it was a piece that would never dissolve. And I'm like, what the heck? That's the plastic plug that's in between the connector. So when that pushes through, it will stay in the vial. So don't think that you've got to try to get it dissolved, because it actually will stay in the vial. So we've got that mixed. We just have a few little pieces in there, but for the most part, it looks good. It's a light straw color. Now we're going to flip the bag upside down. You're going to squeeze the bag and the fluid is going to drain down in. You want to basically milk the bag. So you want to squeeze it and then try to get it, as much of it down into the bag as you can. You're going to have a little bit of residual in the Rocephin. There's the little plug that's still in there. And you can see that most of it's empty. So now we're going to turn it back upside down. And then you're just basically going to rock it back and forth a couple of times. And we have successfully mixed our Rocephin. So we've got our medication. It's connected here. There is just a little bit of residual in the bottom. It's in the bag. From there, you're going to get your drip set ready. Here's, you shut the roller clamp just to keep you from running the risk of getting air in it before we're ready. We're going to take the cap or the foil off the end, and then you're going to spike the bag just like you would spike any other bag. You're going to prime your drip chamber, and then once you have your drip chamber primed, we're going to prime our tubing. All right, so now we've primed our tubing. The tubing itself is going to Y in to your saline, because part of the sepsis protocol is going to be that saline flush bolus. So you're going to have your, by the magic of video, you're going to have your IV tubing that's going to your patient. So this is going to be our IV tubing with our saline that you're going to use the port closest to the patient, which is going to be this port, and you're going to Y your Rocephin in here. So you're going to have your IV fluid, your fluid bolus is going to be running on your main line, and then you're going to come in on this port and you're going to connect your Rocephin in. Once you get your Rocephin connected in, you're going to open the roller clamp up wide open. This is going to infuse as fast as it will infuse through. I'd encourage you, as you're doing this with the Rocephin, you're going to watch this drip chamber go empty. There's roughly 20 cc's of fluid in the tubing for priming. So we want to make sure that we get as much of the medication as we can into the patient. So go ahead and let that drip chamber run empty and then shut it off, so we know that we've given the patient as much of the Rocephin as we can.
Thank you, Ginger. So just a couple of points of clarification. Ginger recorded that as part of a rollout for our sepsis pilot at West Licking. So she's talked about the sepsis protocol, talks about Rocephin or ceftriaxone. Ignore that part. What's important from that video is how do you set the kit up so you can reconstitute the medication and administer it to the patient. So moving on, Dr. Kadish has suggested that we add a protocol for pediatric sepsis. That is a new page. I suggest you take a good look at it once the protocol is formally rolled out. The indications really are very similar to adults. Patients who meet criteria based on the chart that I'm going to show you. If they have at least 3 positives based on their age, then they are qualified for a sepsis alert. If they have less than 3, you can still use the protocol if you ask for medical control. So if the patient meets criteria, what are we going to do? We're going to keep the patient comfortable. We're going to monitor the ABCs. If the patient has an altered LOC, we're going to check a finger stick and treat hypoglycemia if indicated. We're going to take the patient to the closest appropriate facility. For most of us, the closest appropriate facility for a child with sepsis is going to be nationwide, but we have some members of MEC who really the closest appropriate facility is their community hospital. And then we're going to give the patient sepsis fluid bolus based on the fluid bolus algorithm, which is basically weight based. So here's the sepsis matrix. Again, columns are based on the patient age. We're looking at heart rate, respiratory rate, temperature, capillary refill, systolic blood pressure, mental status, and high-risk conditions. If patient meets 2 or 3 or more of these criteria, they're considered pediatric sepsis. And then we'll institute treatment. Keep in mind high-risk conditions. Some of these things we may not think about as much in adults, but children with sepsis or with cancer, children with sickle cell disease, children who've had previous splenectomy or removal of spleen, bone marrow transplants, things like that. Any child with indwelling lines, they are high risk for sepsis, and we should have a low threshold for treatment. There's a new pediatric abuse job aid, again recommended by Dr. Kadish, the 10-4 faces bruising rule. So it's looking for those things that don't make sense. So TEN is torso, ears, and neck. These are places that most children don't accidentally hurt themselves. I mean, these are things that are not considered accidental trauma. Think about faces, the frenulum of the tongue, angle of the jaw, the cheeks, specifically the fleshy part, the eyelids, and the subconjunctiva, or the white part of the eyes. If you see bruising in those areas, unlikely to be due to accidental trauma. The four in the acronym has to do with children who are 4 months and younger typically don't fall or do things that will hurt themselves. A 2-month old does not roll off the couch and onto the floor. And then P under faces P, the P has to do with patterns. Does it look like a hand slap? Does it look like a belt? Does it look like a cord or a wire? So this is a job aid to help you think about, could this child be a victim of child abuse? And keep in mind that if you have a reason to suspect child abuse, you by Ohio law are obligated to report to either Children's Services or law enforcement. So you can't pass that off to somebody else. If you have suspicion, you must report. So let's talk about some protocol tweaks. Quick one, rocuronium is replacing succinylcholine. So rocuronium, our dose is 1 mg per kilogram, either IV or IO. Our maximum is 100 milligrams. Onset is usually within a minute. It's a little slower than succinylcholine, but it takes a minute, maybe 2 minutes in some patients. Duration of action is generally 20 to 30 minutes, which is much longer than succinylcholine, but you can use it for the same indications. Less side effects of rocuronium versus side effects of succinylcholine. We will keep succinylcholine on our drug license as a backup medication if we develop a shortage of rocuronium. So it's not coming off the drug license, but it's moving down in the protocol. It's no longer a drug of choice for chemical paralysis to facilitate and manage the airway. Ketamine. We've made some adjustments. Ketamine is in scope of practice for advanced and for paramedics. It is not in scope for EMTs, but we have added an indication for ketamine where an advanced or a paramedic can use ketamine to facilitate ventilation with CPAP or BiPAP. Again, keep in mind, advanced can only do CPAP. But we can use ketamine at basically 0.3 milligrams per kilogram IV or IO to a maximum of 30 milligrams to help facilitate patient comfort and help them go along with the therapies being provided. My one caution is if the patient is being given ketamine, are they having trouble just because of the anxiety, or they actually air hunger and maybe they don't need BiPAP or CPAP, maybe they need an artificial airway. But that's something you need to do as part of your assessment. But again, if you have a patient who's on CPAP or BiPAP, does not seem to be tolerating it well, you may use ketamine to provide some sedation. If you have a patient with bronchospasm, ketamine also has the additional benefit of treating bronchospasm directly. So it helps reduce bronchospasm as well. Pediatric allergic reaction, earlier in the year, the MFATS board added IM epinephrine to paramedic or EMT scope. We have now pretty much cleaned up the allergic reaction algorithm. So the dosing schedule for epinephrine is the same whether you're paramedic, advanced, or EMT, and it's all weight-based. So 7.5 kilos to 15 kilograms gets 0.1, 15 to 30 gets 0.15, and any child who's over 30 kilograms gets 0.3 milligrams IM, and we'll have a similar dosing schedule for adults. Penetrating trauma, I talked about load and go. We've added the March protocol, which I'll show you in a minute. But load and go situations, it's really pretty much you get in, no stay and play. You do the March, which is basically a quick assessment, manages excessive bleeding, and everything else is done while en route. So we really want to get patients who are victims of penetrating trauma proximal to the elbows, proximal to the knees, involving the proximal extremities or the trunk. You get them off scene and do what you can while en route. And, I think this is important, and you should probably have a similar approach to unstable blunt trauma patients. You get off scene, you do what you can during transport. This is the March protocol. Hopefully, it's not new to you, but basically, it's massive hemorrhage, airway, respiration, circulation, and hypothermia. So we want to control massive blood loss. That's one thing you do before you get in the truck. You get the wound packed off. You put a tourniquet on, or at least put proximal pressure on the bleeding to get it to stop. Airway, you do what you can to maintain the airway with your various maneuvers. You manage respiratory needs. You um, look for any additional bleeding. You provide fluid bolus if you need to. If there's no pulse, start CPR. And then prevent hypothermia. Hypothermia is deadly in trauma patients. Patients who are hypothermic do not clot well. So whatever you can do to reduce risk of hypothermia, you should. Why do we have this emphasis? Well, there are a couple articles published out there that have to do with risk of death if you are transported by EMS versus a private vehicle. So the first one through JAMA surgery, you look at it, and if you look at this group of patients, they looked at penetrating trauma, all penetrating trauma, and then segregated gunshots versus stab wounds, ground EMS versus the back of a private vehicle, and what do we see? Well, if you're looking at all victims of penetrating trauma by ground EMS versus private vehicle, and these were weighted so that the populations were similar. Your risk of dying is probably 5 times higher if you go in an ambulance than if you go in a private vehicle, and that's mostly because the private vehicles get patients to definitive care faster. So, what our goal should be? Our goal should be to get patients off scene at the hospital as quickly as possible. You do what you can during intervention. For the second article through the East Surgical Group, they pretty much it weren't quite as definitive as the JAMA article, but they basically said pre-hospital procedures and penetrating trauma really provide no survival advantage, and in some cases may be harmful, particularly in urban settings. So, get the patient off scene, do what you can while en route. If you have any questions, let me know. But I think you're going to see more and more of a focus on this in Central Ohio. Termination and resuscitation. This was a good question asked by a couple different crews. The question was, if we are responding to the scene, we go to a facility, it's a healthcare facility, healthcare staff are providing CPR, maybe use the AED. Do we have to do 30 minutes before we can terminate based on our arrival time, or can we include the time provided or time when care is provided by the facility staff? So we've made adjustments. So I thought that was a reasonable request. So if you are responding to a cardiac arrest, you get there and trained medical professionals are already providing resuscitative efforts. Their time can be included in the calculation for 30 minutes. So 10 minutes by them, 20 minutes by you, 30 minutes you can quit if you meet the resuscitation standard. And here's really, I tried to clarify as much as can. After 30 minutes of resuscitative efforts with the inclusion criteria met and none of the exclusion criteria present, you can be terminated. And resuscitative efforts mean BLS and ALS provided by healthcare professionals, first responders, and ALS providers. So it doesn't need to be a clock that starts when the paramedics arrive. It could be when the engine company got there. It could be based on when the healthcare providers at the ECF started care. You can start with whatever's the earliest clock time. We've also updated the hospital matrix, basically added capabilities of non-Franklin County destinations. One call out is FMC and LMH are not designated stroke centers, but they can receive, we will allow them to receive patients who are LAMS 1 to 3. And why are we doing that? It's because those facilities, while they're not designated as a stroke center, have the ability to get a quick CT of the brain and give thrombolytics quickly. And that is more important than an extra 10 or 15 minutes to a recognized stroke center that's going to do the same thing. When you're talking about thrombolytics, it has to be given within 3, sometimes 4.5 hours of last normal. And that extra 15 minutes of drive time may end up disqualifying the patient from getting a thrombolytic. So LAMS 1 to 3 can go to FMC and LMH. I think all the other hospitals in our destination or our transport areas are at least a primary stroke center. There's no change in LAMS 4s and 5s. If your transport time is 45 minutes or less and the patient's a LAMS 4 or 5, and you get to a comprehensive in 45 minutes or less, go comprehensive. is the hospital matrix. We've also added guidance on level 3 trauma centers, which we first brought out through an addendum or through some comments in September. So we've added guidance on level 3 trauma centers. It's pretty much word for what Dr. Duzan has already put out there. This is the matrix. I'll leave it for you to just look it up when the protocol comes out. But again, we're trying to identify who's capable of receiving what. Finally, I just as a quick comment, I want to talk a little bit about spinal motion restriction. This is not a protocol change, but we've had some issues recently where EMS brings in trauma patients. Patients should have had a cervical collar on, and they don't. We've had a couple patients brought in where they had cervical spine fractures and they did not have a collar on. So it's really kind of a review and editorial comment. My suggestion is have a low threshold for putting a cervical collar on. If the patient is the least bit impaired, has any distracting symptoms or any significant mechanism of injury, put them in a collar. And if you have any doubt, put them in a collar. Worst case scenario, you spend $20 and we don't need it. Best case scenario, the patient's got a cervical spine fracture, you help immobilize it. If you look at the algorithm that we have, I want to call out 3 parts. One has to do with positive mechanism, which is a high-speed motor accident, falls 3 times the patient's height, anything axial loading, meaning something hits the patient on the top of the head, diving accidents, sports injuries to head or neck, or unconscious trauma patient. That should be considered a positive mechanism. They should get a collar. We still have on here penetrating wound of the neck or near spinal column. There's been some guidance changed where it's really not highly recommended that you have penetrating neck injury, you put a collar on them. Pretty much the damage is done or it can interfere with other things such as airway. There has been some suggestion, and some agencies suggested that if you are an older patient, 65 and up, and you have a ground level fall, that's considered a positive mechanism. You should be collared regardless of the complaint. I'm not quite ready to go there yet. I think if the patient's awake, alert, oriented, not anticoagulated, they may not need a collar if they pass the screen. The second thing has to do with what's a reliable patient. Reliable patient meaning you can count on what they're telling you as being correct, and you can use that as part of your decision tree. A reliable patient is calm, they're cooperative, they're sober, and they're alert, and they don't have any distracting injuries. Distracting injuries are things that are causing undue pain. If they have a femur fracture, they're not going to be able to tell you whether or not their neck hurts because you know what their femur hurts like crazy. So distracting injuries, can keep patients from admitting that they have pain elsewhere. And the last has to do with what's an unreliable patient. Patients who's stressed out because they just wrecked their car. Patient with head or neck injury. Patient with any type of LOC or intoxication. And again, any patient with a distracting injury is considered unreliable. If they're unreliable, they get a cervical collar. Finally, just in summary, please make sure you review the protocol changes when they come out. The protocol is effective January 1st. If you have any questions, ask your EMS coordinator or post them on Basecamp. I think I also need to thank everybody who assisted this year in the protocol review. Like I said, it was the most dynamic sessions we've had in terms of our protocol and making revisions. To the EMS coordinators and others, the Protocol and Education Committee, thank you very much for helping this year. And especially thanks to Cody Smith at Truro and Newton, who spent a lot of time making changes within the protocol. So again, if you have any questions, feel free to post them on Basecamp or send me an email. If you send it to me by email, first thing I'm going to do is I'm going to take your question and post it on Basecamp. So please let us know if you have questions or need clarification.